the spondyloarthropathies and rheumatoid arthritis. Okay. So, as I said, it will be on the spondyloarthropathies and on rheumatoid arthritis, and I'll just be highlighting really the urgency of them. So we've redone and looked at the pathways recently, and really good news is that spondyloarthropathies, along with RA, can now be seen in the early inflammatory arthritis clinic. So they need to come through urgently. The session will look at the ASAS guidelines. So that's the Assessment in Spondyloarthritis International Society classification criteria for axial spondyloarthritis. And I'll also have a little look with you at the one for peripheral spondyloarthritis. I'm going to highlight some key points on these from the NICE guidance, and also look at the NICE quality standards for spondyloarthropathies briefly. That's the QS 170. I'll look at the NICE guidance very briefly, really, just to highlight what would warrant a referral to rheumatology, but from the NICE guidance for rheumatoid arthritis in adults. And we'll look at the NICE quality standards, so the QS 33 for rheumatoid arthritis in the over 16s. So really just looking at the mainly at the quality standards for these, for spondyloarthropathy and for rheumatoid arthritis that apply to physiotherapy. So I've just highlighted the ones that relate to the physio team. And then I'll look at what the NICE guidance suggests physiotherapy should be doing for spondyloarthropathies, and I'm going to highlight some resources for physiotherapy for self-management of spondyloarthropathies and rheumatoid arthritis. So do put a note in the chat if you can't hear me or anything's not visibly clear, and Temi can come in and stop me. But otherwise, I'm just going to run through the presentation and make a note of any questions that you've got, and then we'll have some time for questions at the end. I don't think we'll use the full hour, so I'll be more than happy to answer questions that you may have. So inflammatory arthritis, we're going to be looking at the spondyloarthritis, which is a group of inflammatory conditions that have a range of manifestations. Predominantly, they're split into two fields. So you have your axial spondyloarthropathies and your peripheral. And then within the axial spondyloarthropathies, you have those patients who show up on X-ray, so they have radiographic axial spondyloarthropathy, or you have those that don't show up on X-ray that are called non-radiographic, and they're the ones that you'll see the findings will be on MRI, but they haven't developed enough to be showing changes on X-ray. And then the peripheral spondyloarthropathies predominantly come under or come from these three groups. So you've got your psoriatic arthritis group, your reactive arthritis group, and your enteropathic arthritis group. I'll go into this in a bit more detail, but basically anyone with psoriatic arthritis, psoriasis is quite likely or they have a high probability of developing an arthritis, which would be called a psoriatic arthritis. And then for the enteropathic arthritis, these are for people who have things like Crohn's disease or ulcerative colitis. So let's have a look at these in a bit more detail. Before I go straight through, if you suspect a spondyloarthropathy, whether it's axial or peripheral, or if you suspect rheumatoid arthritis, then they all need to go urgently to rheumatology. And the quality standards, so 33 for the rheumatoid arthritis and 170 for the SPA or the spondyloarthropathy ones, they encourage referral from primary care within 3 days. Okay, so let's go over axial spondyloarthropathy really briefly. It's an inflammatory disease of the spine. I'm sure you all know this already, but I just wanted to start at the beginning. Symptoms start in the mid-teens to early 20s. So axial spondyloarthropathy really is back pain in your young population. So once you've ruled out anything sinister, if a patient's got back pain in their early 20s, you really do need to be thinking about whether or not this is an inflammatory condition as opposed to your standard mechanical back pain, especially in the absence of any trauma. So it's a condition that affects young people, leaving them with increasing pain and exhaustion, and if left untreated can go on to spinal fusion. So it's a condition that if we can pick this up early, can enable people to live really well with the disease if they're under a rheumatologist, and it can prevent the spinal fusion. So delays to diagnosis for this cohort are currently an average of 8.5 years, by which time it's often a bit late, really. So if we can start picking these up earlier, then we're going to be making a massive difference to a cohort of people who are getting back pain in their early 20s. Diagnosing this condition is difficult. That's why it takes 8.5 days. Sorry, days, that would be amazing. That's why it takes 8.5 years, because presentations can be really varied, and it does present often as mechanical back pain. So they might get a recurrent back pain that seems to ease with anti-inflammatories, just like you'd expect with a acute onset back pain that settles down once they start to heal. But looking out for this condition is important, and we'll talk about the criteria that might help you pick them up. So using the ASAS criteria is really helpful, and I'll cover those now in a minute, because we know that answering yes to 4 or more of these gives a higher than 80% probability of a patient having spondyloarthritis. So these are the simple ASAS questions that you can ask. And we've incorporated these into the new e-referral tool that will be coming out soon. So nice straightforward questions. Did your back pain start when you were age 40 or under? So this is an early onset back pain that starts with the young. If it's starting in their 20s, then there's a higher chance of it being axSpA. Again, if it's in their 30s, then there's a higher chance than if they're 40, and if it's in their 20s, there's an even higher chance than if they're in their 30s. So did your back pain start when you're young, i.e. before the age of 40 or earlier? Did your back pain develop gradually? So this is a back pain that started in the absence of any trauma with a gradual onset. And then another key question is, does your back pain improve with exercise? Number 4, do you find that there's no improvement in your back pain when you rest? So often these patients are getting worse when they're at night, when they're not moving, or when they sit down to rest. And then, do you suffer from back pain at night, which improves upon getting up? So they're stiff in the morning. Generally, the signs here are more than 30 minutes. And does it get better as you start moving? So again, as I said before, if there's 4 or more referred, it's urgent. It's 80% chance that it'll be a spondyloarthropathy. So refer these ones within 3 days to rheumatology. Now, then it gets a bit more complicated if it's not 4. So if less than 4, the consensus is that you should probably be considering inflammatory back pain, unless there is recurrent young people that just keep coming back to you with a back pain that develop gradually in the absence of any trauma, any loading or manual handling injury. So if it's recurrent, you can explore if there's other MSK or non-MSK features, and we'll go into this a bit more in the peripheral ASAS questions and the next bit. So I've added in the acronym that NAS have created. So NAS have developed a wonderful resource for patients with spondyloarthropathy, especially axial spondyloarthropathy. And there's resources there for healthcare professionals and for the general public. So within the website's called Act on Axial SPA, and if I haven't already put it in the references, I'll put it in. And just so you know, this presentation will be available after the session, as well as the recording, so you can have the PowerPoint presentation if you want that as well. So the NAS questions are in a slightly different order, but they're basically very similar to these 5. So the NAS ones are quite nice because it's the spine acronym. So S is symptoms start slowly, so that's did your back pain develop gradually. P for pain in the lower back, so did you have low back pain? I improves with movement, so does it improve with exercise? And then N is for nighttime waking, and E is for early onset. So did it start before you were 40? So they're quite similar. So they're quite nice ones to help you just quick fire. What do I need to be thinking about when it's AXPAR? These questions really good. So use either the 5 or the SPINE acronym because they're so similar. Okay, so then if you want to take it to the next level, if you want to keep it simple, then just stick to this. But to just explain this in a bit more detail and look at what the NICE guidance have said and the full ASAS classification for axial SPA. And I hope you're with me on that. SDA is short for spondyloarthropathy. I'm sure you all are. So the ASAS classification for AXPAR looks at, it's very similar to the NICE guidance. The questions are in patients who've had more than 3 months of back pain and the age of onset under 45. So the one before said 40, this one says 45, all quite similar. And you're looking at whether or not you've got sacroiliitis on imaging. So is it on your X-ray or your MRI? And do you have one of these features, in which case you'd refer within 3 days straight to rheumatology? And these features are inflammatory back pain, arthritis, so by that I just mean joint pain. It doesn't necessarily, they don't necessarily need to have confirmation of that on an X-ray. So do they have joint pain? Do they have back pain? Do they have enthesitis? So do they have that insertional heel pain? Do they have eye inflammation, so your uveitis or your iritis? Do they have swelling in the small joints of the hands? That's your dactylitis. Do they have skin inflammation? So do they have psoriasis? And then do they have inflammatory bowel disease, which is your Crohn's or your ulcerative colitis? And there's more. So the ASAS, so that's why I've said if you want to keep it simple, stick to these. If you want to go into more detail, then you're expecting people with inflammatory spondyloarthropathy to improve within 48 hours when they take an NSAID. So this might be the ones that have got low-level inflammatory back pain. They might manage really well, and the first line of management from a pharmacology point of view for these patients is naproxen or long-term anti-inflammatories. PRN. Anti-inflammatories are great. So if they're on NSAIDs like naproxen, they can take it when they need it and then wean themselves straight off it as soon as possible. So the other one of the other features that they would need, so sacroiliitis on imaging, and any one of these, the other ones are a family history of spondyloarthropathy, an HLA-B27 positive, or an elevated CRP. So they only need, on this left side, only one of those, plus sacroiliitis on imaging, in which case you send them straight to rheumatology. Or they might find that they've got an HLA-B27 positive, in which case, because it's not diagnostic, so we know that there's probably about 130 different genetic markers that have been found in spondyloarthropathies. HLA-B27 is just one of them, which accounts for probably only about 30%. So it's not diagnostic, but it is useful to help you build that picture. So if you've got an HLA-B27 positive, it doesn't necessarily mean that they have to have axial SPA, as I'm sure you all know. Just like if it's negative, it doesn't mean that they don't have it. For the ASAS classification, if you have an HLA-B27 and 2 of these features, so sacroiliitis on imaging or definite radiographic sacroiliitis. Sorry, that's not what I should have said. So on the right-hand side, if you've got an HLA-B27 positive and 2 of the SBA features on the left, yeah, you need 2 of them if it's just the HLA-B27 positive, or if you've got sacroiliitis on imaging, then you need just the one, in which case you refer straight to rheumatology. Oh, that was a lot of time on one slide. So I've talked about the simple ASAS questions. You can go into more detail with these, or you can use a NICE guideline, which has got a really nice flow to it. So within the NICE guideline for spondyloarthritis in over 16s, the diagnosis and management, so it's the NG16 I can't believe I know them. I know the rheumatoid and the spondyloarthritis ones off by heart just by the number. Yeah, anyway, I've read it too much. But within the NICE guidance, if you've got a person who's got low back pain that started before the age of 45, still very similar to ASAS, and has had it for more than 3 months, refer the person to a rheumatologist. The NICE guidance tells you exactly what to do, depending on how many signs you have. So to start with, they need to have back pain for more than 3 months before the age of 45. Then if they do, refer the patient to a rheumatologist if they've got 4 or more of these ones here. So the list is, again, if it's before the age of 45, 35 as well, it further increases the likelihood. So that might be one. Waking during the second half of the night because of symptoms. So they've gone into a bit more detail there, saying second half of the night because that's when you're more likely to have a build-up of your inflammation. So you're going to wake with stiffness and pain as a result of that later in the night because you've been still for longer. Buttock pain's also an important marker, especially if it's alternating. So if it's moving from one side, because like if you've got a one-sided pain, that might be mechanical, but if it's moving around, then it's more likely to be inflammatory. Then improvement with movement, sorry, that should be a second one there, improvement with movement or improvement within 48 hours of taking a non-steroidal. Another one might be a first-degree relative with spondyloarthritis, current or past arthritis, current or past enthesitis, current or past psoriasis. Just go to page, I think it's page 10 or 11 in the NICE guidance, and you'll find this list. Now, if they've only got 3 of those from that list, then you might want to investigate more because potentially it may not be spondyloarthritis. And if you've got access to the HLA-B27 test, then do it. And if it tests positive, send them through to rheumatology. If not, if they've not been to physio, send them through to physiotherapy. Okay, so just one thing to note, and I'll say this twice because I think when I was at university, definitely I was told that axial SpA was something that affected young men and not women, but we know now that that's not the case. It affects the similar number of women as men. What you do find that is often the men have more radiographic evidence, whereas the women are showing up more with MRI evidence. And the thing to note there is that the disease burden is exactly the same. So don't think of axial SpA as a disease that affects young men anymore. It happens in both groups, so men and women are both affected equally. Also, remember, like I said already, it can occur in people who have a HLA-B27 negative, and just because they're positive doesn't necessarily mean, I'm sure you know that anyway, just because they're positive doesn't mean that they necessarily have it, but it may increase your likelihood. And it might be present even if you've not got sacroiliitis on an X-ray, because the ones that's showing it on a plain film X-ray are probably those that have had it for longer, so they've gone on to get the bone effusions. So MRI is really, really useful now because we can pick it up sooner. Okay, deep breath. I'm going to take a drink. So we've talked about axial SpA. Now we're going to talk about peripheral spondyloarthropathy, so peripheral SPA. So these are your peripheral inflammatory arthritis, and I'll deal with rheumatoid arthritis, which is another peripheral inflammatory condition after this. But if you're thinking someone could have been axial, but they've got peripheral joint pains, then you can go down this route. So predominantly it's your psoriatic arthritis, your reactive arthritis, your enteropathic arthritis. So it's often unilateral, affecting mainly the one side of the body. So you get these patients that are coming to you that they've got the whole left side that feels sore or swollen or affected, then it might be an alarm bell for your peripheral inflammatory arthritis. So within the NICE guidance, you need to, the advice is that you urgently refer people with a new onset inflammatory arthritis, especially if they have a history of psoriasis. So and also if they have dactylitis or if they have enthesitis without apparent mechanical cause, send them to rheumatology for spondyloarthritis assessment. So it's new peripheral inflammatory arthritis, swelling in your fingers or swelling at those points. So enthesitis is inflammation and swelling at the site where the tendons and the ligaments attached to the bone. So if it's one joint, something like a plantar fasciopathy or lateral epicondylalgia or an Achilles tendinopathy, do your normal physio for those. But if you get these people who have no apparent mechanical cause and they tend to be multiple sites, then you should really be wondering if these are peripheral spondyloarthropathy. So to build your index of suspicion, we want to, sorry, I haven't got that far yet. Hold on, that's the next slide. So still within the NICE guidance, we want to be referring people, sorry, I have 2 slides in there. So referring people with enthesitis without apparent mechanical cause to a rheumatologist if, so not just one joint, like I said, if it's persistent, if it's multiple sites, or if you've also got back pain, and then your non-MSK signs, so your eye inflammation, your psoriasis, your inflammatory bowel disease, such as Crohn's or ulcerative colitis, or a relative with spondyloarthritis or psoriasis. Okay. The ASAS criteria might make it a little bit easier to process all of that. So you're looking for patients who are coming to you with multiple painful peripheral joints, especially if one-sided, plus pain at your tendon or ligament insertions, or sausage-like swollen fingers, so dactylitis. If they have any of those 3, so peripheral arthritis, enthesitis, insertional pain basically, or your swollen fingers, plus one of these SBA features which are on the left, so if they've got any of those 3 plus uveitis, psoriasis, inflammatory bowel disease, a preceding infection, especially if genital, urinary or gastric, a positive HLA-B27 or sacroiliitis, then send them through to rheumatology. And if not, look for the 2 of these SBA features on the right. So that's arthritis, enthesitis, swelling in the sausage-like fingers, inflammatory back pain ever, not necessarily now, or a family history of SPA. So I think this one's quite nice for your peripheral spondyloarthritis, whereas to simplify things for your axial, stick to these 5 questions because they should pick it up. Okay, so have we done that? We've done that. Let's move on to rheumatoid arthritis. So, I mean, rheumatoid arthritis is a peripheral inflammatory arthritis. It causes joint pain, swelling and damage, resulting in joint stiffness and weakness. And the key things to pick this up, according to the NICE guideline on rheumatoid arthritis in adults, the management that was published in 2018, this one suggests you refer specialist opinion any adult with suspected or persistent sign of itis or joint swelling of undetermined cause. I think that's key, undetermined cause. Refer them urgently, even with a normal acute phase response, negative anti-citric citrullinated peptide, in the CCP, antibodies, or even if negative rheumatoid factor. You'll refer them if they're all negative, if they've got pain in the small joints in the hands and feet, multiple joints affected, or if there's been more than 3 months since onset of symptoms and seeking medical advice. So that's the NICE guidance for RA. And yeah, I've only put that little bit in on that rheumatoid arthritis because I think generally GPs and primary care are very much better at picking up RA, and it's much easier to pick up than the spondyloarthropathy. So back to the quality standard now. So I've looked at axial SPA, the ASAS and the NICE guidance, and I've looked at peripheral SPA, the ASAS and the NICE guidance there. Now I'm going to look at the quality standards for spondyloarthritis and the one for rheumatoid arthritis. So within the quality standard 170, which was brought out in 2018, there's 4 statements really that kind of link into physiotherapy, either from a identifying and referring point of view, or from a what should physiotherapy be doing. So I've just highlighted those here. So the first statement is refer adults with suspected axial or peripheral spondyloarthritis to a rheumatologist, like we said already. Statement 2 is adults with suspected axial SPA and an X-ray that does not show sacroiliitis should have an MRI using an inflammatory back pain protocol. So I put that in. It's not really physio treatment, but it's important that we know that, like we said at the start, if they can have radiographic or non-radiographic. So X-rays are radiographic. They may still have sacroiliitis that can only be picked up on MRI. So if we're suspecting axial SPA, your MRI is really your first diagnostic. Yeah, if you've only got, based on the NICE guidelines, you've only got 3 key points, then you do your HLA-B27. But if you've got 4, you're going to go straight to the MRI. Yeah, if your X-ray is negative, but you're still thinking clinically represent with inflammatory back pain. So then here, finally, on our talk about physiotherapy for our inflammatory conditions, statement 3 talks about what physiotherapy should do. So physiotherapy, quality statement, adults with axial spondyloarthritis are referred to specialist physiotherapists for a structured exercise program. Sorry, I've got a few typos on this slide. So basically, physiotherapy is in statement 3. Adults with axial SPA should be referred to specialist physio for a structured exercise program. And then statement 4 is kind of physio as well. So adults with spondyloarthritis are given information about their condition. We're in a great place to do that. And they should be told which healthcare professions are involved in their care and how and when to get in touch with them. So this basically means that patients should have access to their urgent rheumatology helpline, but also that GPs should be able to refer patients with spondyloarthropathies in for urgent flare-up management. Okay, so that's your spondyloarthritis quality statements. And now on to our rheumatoid arthritis quality standard. So the early inflammatory arthritis national audit is primarily at the moment based on the quality standard 33. So it looks at the statements within for rheumatoid arthritis. However, as I said before, within BHIUT, we're now going to be able to refer spondyloarthropathies in for urgent treatment via the EIA clinic. That's not the same across nationally. Not all hospitals are doing their getting their spondyloarthropathies in urgently that way, but that's how we're going to do it because we've got the EIA clinic, the urgent setup for that works really well. So the standard from the rheumatoid arthritis side of things, statement 1 suggests that adults with suspected persistent synovitis affecting more than one joint or the small joints of the hands and feet are referred to rheumatology services within 3 working days of presenting in primary care. And statement 3 suggests that adults with rheumatoid arthritis are given opportunities throughout the course of their disease to take part in educational activities that support self-management. So here, physio has a key role in helping patients to keep joints mobile and maintain strength, function, and movement. Okay, so within I might just take a break there and just check in, make sure everyone's still with me, and see if you've got any questions up to this point. Okay. So Tammy or anyone, is there any? There's quite a bit of chat in there. Is it mainly names that are in there? Have anyone got any questions they want to ask me at this point? No questions? Can everyone hear me okay? Someone say yes? Type in yes in the chat. Hello? Yes, thank you, Marianne.
Has anyone got any questions for Chrissy?
Yeah, so I've gone over the ASAS, the NICE in quite a lot of detail, but if we go back, I'm going to go back to the simplified bit. So I'll go back to the bits to remember at the end. So back into what do the NICE guidance say for physiotherapy to be doing for spondyloarthritis? So within the guidance, we've got a clear plan of what we should be doing. So we need to be keeping this in mind, but obviously we're going to tailor every assessment and treatment to the patient that's in front of us and be holistic and meet their needs. But because they've got a spondyloarthritis, then we want to be making sure that they're aware of the fact that exercise is the cornerstone of management of an inflammatory arthritis, really. So I'll extend that across from spondyloarthritis into rheumatoid arthritis. If patients with these conditions stop moving, they fuse, their joints stiffen up, they lose their flexibility, they get weak, they deteriorate in function, they lose the ability to work well and live well with their conditions. Whereas if we can get exercise in early on in their disease management, then they're going to do much better. So the NICE guidance highlights that for spondyloarthritis. Unfortunately, it's not clearly in there for as clearly as it is for spondyloarthropathy in the rheumatoid arthritis, but there is still lots of ways we can extrapolate it across. So within spondyloarthritis, we should be giving a patient a structured exercise program. So a plan of exercises tailored to their needs and to their changing needs. And you really do need to make sure they've got stretching, strengthening and postural exercises for, if it's axial SPA, for the back. Often the ribs are affected because, as we know, the spondyloarthropathy affects the tendons and the ligaments as they attach onto the bones. So the rib cage can become quite stiff. Often you find in a history, patients develop chest pains. They will be sent chest x-rays, heart scans because of this chest pain, but it is often just an inflammation around all those tendons and ligaments around the rib cage. So deep breathing exercise and aerobic exercise is really important to keep all that rib cage nice and mobile, to keep the swelling out and keep the tendons and ligaments nice and flexible. Because we know, moving on then to spinal extension, because we know that patients tend to come into this flex posture, they lose extension. Doing extension regularly helps maintain that for longer. And range of motion exercise in the lumbar, thoracic and cervical sections of the spine are really important. So spondyloarthritis, and the focus through NAS is on low back pain, but it does affect the whole part of the spine. So flags for an inflammatory back pain are often patients that are coming in with their thoracic spine pains as well as low back pain. Just look for that in the history. So exercise-wise, treat as you see, assess, find out where they're weak, where they're stiff, what you can do in terms of physio, but make sure they've got a structured exercise plan of regular stretches, regular strengthening, regular spinal range of movement extension, get them exercising aerobically, get them doing their deep breathing. Yeah. So within the guidance as well, they recommend hydrotherapy for patients with spondyloarthritis, and this applies for peripheral as well as axial, just because you can get in and obviously move much more easily with the support of the water, move much more freely and mobilize those joints really nicely. Okay, so from a rheumatoid arthritis point of view, we know that physiotherapy treatment is important in helping patients manage their disease. And we work often with rheumatoid arthritis patients, perhaps later in their disease process, which for me, I personally, I think we really do need to be, and lots of patient organisations during COVID are really working to support patients earlier on in their disease process, to just like we do for spondyloarthritis, get them exercising, get them moving. It will help maintain their function and their joints, their movement and their strength early on for them to live better. So jointly with occupational therapists, physiotherapists, educate patients in joint protection strategies and using assistive devices and performing therapeutic exercises. So we as a team exercise, physiotherapy, help maintain joint flexibility and strength. I said that loads. we're there to highlight the importance of range of movement exercises and strengthening. So patients should be coming to physiotherapy earlier on for patients with inflammatory arthritis, such as rheumatoid arthritis, and they'll do much better. Now, there are, and this is where I'm kind of coming to an end, so I'll be open to answering lots of your questions, but the resources that are out there are fantastic. So we've got the new, I talked to you about the NAS website, so that's really nice for educating patients and the general public on spondyloarthritis, especially axial SPA. But also there's a section there for the public, but also for healthcare professionals, and you've got talks from GPs, rheumatologists, so all primary care, secondary care, community, really, really nice website there, probably one of the biggest resources that are out there for a single condition. NAS have done a nice series of stretches on YouTube videos. There's 11 YouTube videos called Stretches for Your Daily Life, and I'm going to bring these websites up in a minute for you to have a look at. I can't talk well enough about the NNAS website, so the National Rheumatoid Arthritis Society charity website is fantastic. I'll bring that up and show you some things in a minute. So they've got lots of new schemes running through NRAS for your rheumatoid arthritis. So this covers not just your seropositive, so the ones that have got bloods that confirm rheumatoid arthritis, but also if you're seronegative arthritis, there's also rheumatoid arthritis, refer them to NRAS. You can, on NRAS, patients can self-refer or therapists can refer in for a new to arthritis program or a managing their rheumatoid arthritis program. So there's two entry points for a self-management program, and there's also a newly launched last year e-learning modular program called Smile through NRAS, which is aimed to help support patients in their self-management. So it's an online e-learning tool for patients to improve the management and better understand their condition and how to self-manage it. So there's some nice information starting to come out from NHSX, tools and digital playbooks for rheumatology. So there's a nice digital pathway on there. Again, the link's on there. And there's a nice stretch program on versus arthritis as well, so a YouTube program. Yeah, we've also got some really nice YouTube links. Not put them on here, but I'll try and add them in after. From our pain team, so Lee Matthews has got a Pilates and a pain stretch YouTube website, which we can direct patients to, which is really, really fantastic as well. So if everyone would like me to now, I can pop up I'll pop into the websites for the NAS daily stretches, just so you can have a look at it. And also I'm going to jump onto the NRAS website for you to have a look. Would you like me to do that? Just have a few yeses in there and I can do that, or otherwise we can go straight to questions. Yeah? Okay, we've got a couple of yeses, yeah, fine. So let me stop sharing my presentation and then I'll hopefully, we tested this before and when I go onto the website, I go on mute. So what I'm going to do first, I'll go on to NRAS and I'm going to try and show you a couple of sections of the website. If that doesn't work, at least I've taken you to the main page, okay? So within NRAS, and this is what I'm going to try to show you, so NRAS is the National Rheumatoid Arthritis Society website, charity organisation, absolutely fantastic website. There's information on there on DAS and how to do a DAS. There's a talk from the lady who set up the site, Ailsa, who talks for a good 5-10 minutes about self-management, educating patients on the importance of knowing how to do their own DAS score, the importance of them getting their bloods and understanding their inflammatory markers and when they're raised and how that's used within the DAS score. There's sections on exercise for rheumatoid arthritis and when to start, what it's safe to do, different types of exercise. There's videos in there for all the different joints. You've got shoulder, knee, ankles, hands. Really, really nice resource. So let's have a little look up there and let's see if I can share that with you.
Christy, you're on mute.
She's on mute as she can't maneuver the website and speak at the same time. I think she may have mentioned this before.
Temi, can you see when I'm on the end, when I had it on? Can you see that I've searched on and I've brought up a site? I'll reshare and see if you can see. This is quite hard to do, but let's have a go.
Okay.
So back to sharing. Back into InMers. So I've done a search on exercise, and I'm going to try and just click in and show you where the exercise section is on the website. Okay, let's see if it works.
I can see Christy. I hope everyone else can see. Okay, that's fine.
Yes, I can.
Thank you.
Okay, so there's loads in there. You've got, is it right? Is it ready for me? Exercises for the hands, exercises for the legs. Did you get to see a few things on there? There's a really nice search tool at the top. Just type in exercise, or you can type in DAS score. There's loads in there. So I just direct patients to that, and I usually give them the link to the exercise bit and then just let them have a play about. Okay, so then the next one is the NAS daily stretches. So for your inflammatory spondyloarthropathies, especially inflammatory back pain, I'll share the NAS link here. This one's quite hard to get to, so to find it, either use the link I'll send you, or you go into you can all hear me now, can't you? I've stopped sharing. I'm hoping you can. Temi, you can hear me at the minute, can't you?
Yeah, I can hear you.
Okay, so to find these ones, they sit on the A Stretch website, but I'll give you the link anyway so you can get to them. Let's have a look at these. So back into Chrome, stretches.
Yes, we can.
This 46-pound grout pen deep cleans any bathroom or kitchen tile in seconds. Its patented formula tackles grout stains at a microscopic level, leaving behind crisp.
We know from talking with people with axial SPA that when you wake up in the morning, you can feel very stiff in your joints and in pain. This is an especially difficult time for those of you who may be in a flare. These exercises are designed to get you gently moving and prepare your body for the rest of the day. Please don't worry if you can only do a few repetitions of each exercise. Some movement is certainly better than no movement. So when you are ready, gently roll onto your back with your knees bent up and feet flat on the mattress, or if you prefer with your
Okay, so you get the idea there with the daily stretches. There's a few in there. Have a little look. I usually just get patients who want something general to go in and try one a day and then pick out. They develop their own toolkit and they have their own resource of exercises and stretches. So there's some other ones. I'll just show you, I think, one more thing. So the Versus Arthritis YouTube channel and the stretching series that they've got on there. So let me try and share that. Yeah, so I think these are, we were looking at whether or not we were going to restart our classes in-house for our gentle stretch. We used to run a head-to-toe stretch class, but to be honest, these online YouTube channels from Versus Arthritis and from NAS probably quite nicely replace those and give patients something that they can do and play in their own time without having to be tied to coming into the hospital at certain times. Obviously, they miss the peer stuff, but they're really useful resources anyway. So, open to questions really. Does anyone have anything they want to ask? I've really focused it on helping me and everyone to understand what the ASAS criteria are, so we can pick up these patients better and identify the ones that aren't mechanical and pick up the inflammatory ones. But I think it's important that as physiotherapists, we don't suddenly go, okay, they're inflammatory, let's refer to rheumatology, they don't need physio. We can't, they may well, I think they need rheumatology because they need the diagnosis, but they still need exercise, strengthening, range of movement. So don't see a rheumatoid patient and think, okay, and I'm sure you don't, but there's so much that can be done. The more work that I've done within physio as a rheumatology physio, the more I've seen and feel that poor old rheumatoid arthritis patients really should be coming to us perhaps a bit sooner, and there's so much that we can do early on and all the way through their disease progression. And it might just be one session. Yeah, move it. It's safe to move it. If that hurts, these are different exercises that you can do in a supported way, just like you would do with an acute injury. So manage your pain, help it to move as a passive, active assisted, find a way to move it. Otherwise, it's going to become more deformed and more, fused. So movement's really important, as is strengthening. So there's loads that we can do for rheumatology patients. To start with, we need to identify that they're inflammatory, get them to rheumatology as quickly as possible so they get their diagnosis, but also support them throughout their lives with physio and exercise, and understanding the needs and the benefits of exercise and movement to live better. Okay, any questions? Pop your screens back on and give me a wave or ask anything. I'll put the link for the, yes, I will, no problem.
Hi, I've got a comment to give actually. My name's Rimi, I'm a GP. It's just
Hi,
about,
Rimi.
hi, and thank you for the talk, first of all. Really informative and really helpful, because I feel like some of these forms of arthritis do get missed. So one of the things just from recent experience for psoriatic arthritis is the patients who have a very mild form of psoriasis that are often missed, and actually in this particular person a flexural psoriasis, which was thought maybe was like a sweat rash or intertrigo, but actually was then diagnosed with psoriatic arthritis. So it can be very, very mild form of the skin condition and not necessarily the classic severe plaque psoriasis. So it was just an observation for my peers as well, because that kind of caught me out, just to kind of remember that too.
That's really helpful, Rimi, I think. So I think we do need to be careful, don't we? We're not going to go, oh, multi-joint pain, refer them all to rheumatology. But the chances are, I think if you're looking, you're building that inflammatory picture. Are there eye problems? So a word of note, anything, and if you don't know, if you do know, sorry, but if you don't, it's always worth mentioning. If there's any eye or any suspicion of uveitis or iritis, they need urgent care. So they're straight to A&E or Moorfields, Queen's Hospital, Monday to Friday within normal working hours. There's a urgent eye clinic there. So there are risks of them losing their vision if they've got uveitis or iritis, so inflammation at the front of the eye. They need urgent care. For your inflammatory bowel disease or your psoriasis, it's not as urgent, but they are inflammatory conditions, and if you're getting a few of them, get them to rheumatology to rule out, make sure they've not got spondyloarthritis. Rimi, it's really, really nice to get your feedback there on there are many different types of psoriasis. So like you say, it's not just the plaque psoriasis, it's different variations. So even when I'm getting someone with lots of clinical signs from either peripheral or axial ASAS and eczema, then I might be going, is it a mist or a mild psoriasis? Is it worth erring on the side of caution? And if you're not sure, then there's lots of tools that you can look at, or you can, if you don't think you've got enough to send to rheumatology, then advise the patient, like, this is your nice guidance, these are the criteria. If you develop more, then come back and we refer you on. But we're not, if you're sitting there borderline, give them all the normal management. The benefits of exercise for arthritis are massive. So you can at least do that and then tell them that if they're not managing with that, come back if they develop more signs and they can get referred to rheumatology. Thanks, Rimi.
Thank you. Thanks, Christine.
Anyone else? Any other little nuggets like that are really, really helpful for all of us. If anyone's got anything they'd like to share, then please do. Okay, so I'll put the stretches for your daily life in the chat. They're the NAS ones, just going in there. I'll put the link to the exercise videos from NRAS in the chat as well. So that's the second one going in. I'll put the link to the versus arthritis series in here. Yeah, so within the work that we've done recently on pathways, we've really tried to, there's a whole new section for rheumatology within the pathway now that's been expanded right out using I'll put the link in actually, so the BSR adult rheumatology guidelines. I'm going to paste the link in now, hold on. So the pathway for rheumatology has been really based around that. So it gives you a whole wealth of information on, if you're not sure, what things rheumatology want to see and what they don't. I'll put the link to that document in. Really, really useful document. What else? Yeah, there's a few resources in there. So within the slides, I've put the links to some of that as well. I'm going to put one more in